Presenting Mr. R, a 17-year-old male who came with complaints of deliberate self-harm. On 14th of October 2023 at 7:30 p.m., he consumed 10 ml of 36% monocrotophos. He was found unresponsive by his relatives, taken to a nearby hospital. He was intubated in view of respiratory distress. He was treated with atropine. On 22nd, extubated, and 2 days later, he was discharged. Post-discharge, after 2 days, he again started developing cough with copious watery expectoration and rhinorrhea, along with loose stools and vomiting, along with the drop in sensorium. He was intubated in an outside center and was referred here for further management. Otherwise, patient did not have any underlying psychiatric illness and no history of previous similar attempts so far. So when he came to the ED, he came with a blood pressure of 80/60 with cold peripheries, tachycardic with a pulse rate of 148. He was intubated. He had this moist skin. Other system-wise normal. GCS was 10. Best GCS was 10T by 15. Pupils were 1 mm, reactive to light. So in this patient, we were thinking of delayed onset cholinergic crisis. Baseline investigations showed a low cholinesterase level of 3,247. And otherwise, the investigations were fairly normal. And so for him, the diagnosis which we made was deliberate self-harm with monocrotophos 36%, with cholinergic crisis and a probable dope. On day 26 post DSH, he kind of developed this abnormal movements in the ward. So what could this be? Any thoughts? So the differentials we considered for this were, first thing is extrapyramidal syndrome due to OP poisoning. We were also thinking whether there is a possible drug which could cause this, like most commonly metoclopramide, TCAs, and prochlorperazine. Also, if he had any baseline disorder like Wilson's disease, which could possibly be. So when we reviewed the drug history, he was not on any of these medications. And previously also, he did not show any features of Wilson's disease. So we were thinking it's mostly an extrapyramidal syndrome due to OP poisoning. So now I would like to talk on extrapyramidal syndrome due to OP poisoning. This is one of the delayed but rare manifestations of OP poisoning. Mostly the timing of onset is between 5 to 15 days post consumption of the compound. So it's described in very few case series across the literature. So I looked into 4 of these case series. So while looking at each of the patients presented there, the first one was the one from Karnataka, where a 30-year-old female who consumed 40% triazophos developed extrapyramidal symptoms, which is mainly in terms of coast-resting tremors and cogwheel rigidity on day 6 post-consumption. So this patient was given amantadine 100 mg thrice daily, and she was given the same for 14 days, and on follow-up, she found she was completely well with no signs of relapse. Whereas on a 67-year-old male in a study done in Japan, where the patient developed the syndromes on day 5 post-consumption, mainly consisting of resting tremors with pill rolling and cogwheel rigidity. He was given supportive care. No central anticholinergic was given. So this patient had tremors and rigidity, which persisted on day 30 as well. And there are 2 other case reports from pediatric population, where a 12-year-old girl who consumed phentheon developed the same on day 4 of illness. She was given supportive care. This symptoms relapsed, and she did not have further symptoms of the same. And there's another one case report from Delhi, where 14-year-old girl consumed 50 ml of an OP compound, where she developed this short shuffling gait after 4 weeks of consumption. She was given trihexyphenidyl, levodopa, carbidopa combination, and amantadine. She was given for a duration of 2 weeks, and mild dystonia persisted. So these symptoms are generally transient, whether being treated or not, few show relapse, whereas few don't. There is a study done in CMC, where they have observed patients developing EPS with the ones who do not develop EPS. So here, out of 32 patients, 17 of them develop EPS. And comparing the ICU stay and duration of ventilation, the patients who develop EPS have prolonged duration of ICU stay, prolonged duration of ventilation, and the need for tracheostomy is also more in the ones who develop EPS, whereas the ones who do not develop EPS have less of these. But then there is no difference in outcomes such as death. So our final diagnosis is deliberate self-harm due to monocroto for 36%, cholinergic crisis, probable dope, and OP-induced extrapyramidal syndrome. And our patient, coming back to our patient, we gave injection promethazine, which has little anticholinergic property as well. Half an hour into promethazine, patient's movement disorder resolved, and he was perfectly all right. And he was started on trihexyphenidyl and is planned to be given for a duration of 2 weeks. He was monitored throughout the ward for any relapse of symptoms, but then symptoms completely resolved. And he was reviewed in OPD after 1 week, and he's doing well. So learning points, extrapyramidal symptoms or manifestations of OP poisoning, it's mostly self-limiting. Sometimes they require centrally acting anticholinergics. Thank you.
Is it dose dependent, or like any OP compound carbamates can cause, or it's only the OP compounds that can cause any specific?
Based on the articles I reviewed, it does not depend on the dose. It does not depend on the type of compound as well.
Any other questions? The next case is by Dr. Sharon Nikita. The next step, medicine 4.